intracellular ions. To note is the role of the sodium-potassium ATPase pump, which helps maintain the difference in this cationic concentration between the extracellular space and the intracellular space. It is important to note that it is present in all cell membranes. So that's just a diagrammatic presentation of what I've talked about. You will appreciate that this is the intracellular space, with potassium being the main intracellular ion, and in the extracellular space, you have sodium being the main extracellular ion. In the extracellular space, you have the interstitial fluid and plasma, and the difference between these two is the amount of protein, which is higher in the plasma component compared to the interstitial fluid space. Then we need to understand what is the role of the kidney in when it comes to sodium and potassium balance as well as water balance. So this is just a diagram showing the nephron, which is the basic functional unit of the kidney. You have your glomerulus there, also known as the renal corpuscle, which generates the glomerular filtrate, and it is basically composed of water, many different ions, and small molecules. Then going down, you have your tubular system, where you have the proximal tubule. Trying to trace my cursor, but anyway, you have the proximal tubule, the descending loop of Henle, the ascending loop of Henle, the distal convoluted tubule, and finally your collecting system. So what happens in the PCT, the proximal convoluted tubule, is basically you have reabsorption of most of the things: sodium, chloride, potassium, water, glucose, and acids, bicarb, calcium, and phosphate. However, you also have secretion of ammonium and creatinine. In the loop of Henle, the descending loop of Henle is permeable to water, so most of water reabsorption occurs in this area. Then you have the ascending loop of Henle, which has a thin part and a thick part. In the thin part, you have mainly reabsorption of sodium chloride, whereas in the thick ascending limb, there is, in addition to reabsorption of sodium chloride, is reabsorption of ammonia. In the distal convoluted tubule, what mainly happens there is the reabsorption of sodium and chloride, which is around that area. Again, when we go down to the collecting duct, you have more reabsorption of water and as well as sodium and chloride, and there's also secretion of ammonium, hydrogen ions, and potassium. So we also need to appreciate that at least for any normal human being, you need to take at least 500 ml of water in any given day, but this can go beyond 500 ml depending on the person. We also need to keep in mind there's something called insensibulosis. This is the amount of water that you lose through stool, sweat, the respiratory tract. And there's also water that is generated within the body, which is referred to as metabolic water, and this translates to around 400 ml in a day. The kidney plays a big role in trying to maintain this constant body water content, and also to maintain the osmolality at a range of 282 to 95. That is why you really need to understand the basics when it comes to the regulation of all these things. So various hormones play a role when it comes to regulation of sodium, potassium, and even water within the body. So in any event, when you have a volume contraction from whatever reason, there is activation of the sympathetic system. As you can see there, there's also activation of your renin-angiotensin system. So you have renin-angiotensin 1, angiotensin 2, and finally aldosterone. And you also have, on the other hand, you have inhibition of anti-natriuretic peptide and brain, atrial natriuretic peptide and brain natriuretic peptide. And also you have an increase in the release of ATH from the brain. We'll see how all these hormones come into play. But basically, those are the main hormones that play a role when it comes to regulation of sodium, potassium, and water within the body. This is also a diagram just explaining the same thing. If there's any alteration in the extracellular fluid volume or sodium content, this is sensed by the volume receptors, pressure receptors, and also the macula densa within the kidney. And when these changes are sensed by these various receptors, there are effector mechanisms that are brought into play. We've already talked about activation of the renin-angiotensin system, activation of the sympathetic nervous system. You have inhibition of the atrial and brain natriuretic peptides, and inhibition of the prostaglandin which all act to try and normalize the extracellular fluid volume and also the sodium content and potassium content. So this is just a summary table of just showing where all the different hormones, where they are produced and their function. You'll appreciate renin. You've already mentioned that it's from the kidneys. Epinephrine or epinephrine, it's from the adrenal medulla. Angiotensinogen is from the liver. Aldosterone is from the adrenal cortex. The antidiuretic hormone is produced in the hypothalamus and stored in the posterior pituitary, whereas the natriuretic peptides are in the heart. So this is the same. So then now we move now to the topics of discussion for today. We'll start with hyponatremia. There are various ways in which hyponatremia can be classified depending on the concentration, the serum concentration of sodium. So you can have either mild, moderate, or severe. Moderate being a concentration between 125 to 129. 129 to 135 would be considered as mild, and anything less than 125 is considered as severe hyponatremia. Hyponatremia can also be classified according to the time of development. You can have, with the cutoff being 48 hours, so anything less than hyponatremia developing in less than 48 hours is acute, whereas hyponatremia developing over more than 48 hours is considered as chronic. Hyponatremia can also be classified according to symptoms, so you can have symptomatic or asymptomatic, the patients who don't have symptoms. And you can also classify hyponatremia based on the serum osmolality. So you can have hypotonic, isotonic, or hypertonic. We'll look at this in more detail. And you can also classify hyponatremia based on the patient's volume status, whether they are euvolemic, hypovolemic, or hypervolemic. So regardless of whatever classification system you use, the clinical manifestations will be the same. So most of the patients will present with neurological features, mainly fatigue, headache, can come in vomiting or having nausea, can have confusion, seizures, or can even be in a coma. And all these symptoms develop at different rates depending on whether it is acute or chronic hyponatremia and the level of the serum sodium concentration itself. So for example, a patient who has chronic hyponatremia will only develop mild symptoms of fatigue, headache, nausea, vomiting, and the serum concentration of sodium falls to around 120 to 125, whereas the concentration will be higher if this is happening in an acute setting. Confusion, seizures, and coma are considered to be more severe symptoms, and these usually develop at lower serum concentrations of sodium, much lower when it is in a chronic setup, and at least between 120 and 25 when the patient is presenting acutely. And all the presence and severity of these symptoms is related to the severity of derangement and the speed at which the derangement develops, whether it is acute or chronic. So basically, this is a diagram just showing the different hormones that we've already talked about. You'll appreciate that angiotensin and aldosterone affect the reabsorption of sodium directly, and also reabsorption of water indirectly. However, you'll note that aldosterone inhibits reabsorption of potassium, and ANP and BNP, as we said, they will inhibit reabsorption of sodium. To note is the role of antidiuretic hormone. It only has an impact on the reabsorption of water with no direct effect on reabsorption of your sodium or potassium. So it majorly affects your water reabsorption. We've already talked about this. ADH is produced in the hypothalamus and it is stored in the posterior pituitary as shown in that diagram. And it stimulates or causes systemic vasoconstriction and increases water reabsorption in the distal tubules and collecting ducts within the kidney. The main factor that stimulates ADH production is reduction in your blood pressure. These other two may or may not have a direct effect on release of ADH from the posterior pituitary. So looking at This diagram will help us look at the different causes of hyponatremia, as well as how to classify your patient. As we talked of the different criteria that you can use to classify hyponatremia. So from this diagram, you will appreciate that we can classify the patient based on their volume status or their serum osmolality as shown. So when you're talking of, so most of the times when you discuss hyponatremia, what will be discussed commonly is hypotonic hyponatremia, this part of the diagram. But that doesn't mean that you forget about patients who have hypertonic hyponatremia or isotonic hyponatremia. So basically, the normal serum osmolality is between 280 to 295. So if a patient has hyponatremia but with a normal serum osmolality, then the patient is said to have isotonic hyponatremia. And the main causes of this are usually high protein or high lipid levels in the blood. And on the other hand, if you have low sodium concentration but with a high serum osmolality, then you think of anything that would increase your osmolality. So things like glucose, so patients with hyperglycemia, patients who received mannitol for one reason or the other, or patients who have been exposed to radio contrast agents. Then the main cause of hyponatremia lies within this area where you have hypotonic hyponatremia. The sodium concentration is low and the serum osmolality is low. Then you further classify a patient, is a patient in hypovolemia, or are they euvolemic, or are they hypervolemic? It is easier to recognize patients who have heart failure, liver failure, nephrotic syndrome, or advanced kidney disease with kidney failure, since they come in fluid overload. So if a patient has hypotonia, has low serum osmolality, has hyponatremia, and they appear fluid overloaded, then you can comfortably classify them as having hypervolemic hyponatremia. Then hypovolemic hyponatremia is also easy to decipher. So you go ahead and measure the urine sodium. And if it is less than 10, it means most of the loss is not occurring through the kidneys. So meaning it is extrarenal. So maybe in the GI or any other system. So if the patient is having diarrhea, vomiting, or dehydration for whatever reason, then that probably will cause them to have a low urine sodium. They'll be hypovolemic, and they'll also be hypotonic and hyponatremic. So you'll be able to classify them in that state. However, if you do the urine sodium and it is more than 20 milliequivalents, it means the patient is losing that sodium to the kidney, and these are the possible causes of such renal sodium loss. So use of diuretics, use of ACE inhibitors, any adrenal insufficiency, and also what we call cerebral salt wasting syndrome. Then this other column is also common, but can be a bit difficult to make a diagnosis, but by elimination, you will find yourself in this box. So if a patient is hyponatremic, has a low serum osmolality, and in terms of volume status, you cannot say they are hypovolemic, neither are they hypervolemic, so meaning they are euvolemic, and this would be the probable causes of hyponatremia in such a state. So you have the syndrome of inappropriate ADH secretion. You can have postoperative hyponatremia, e.g. patients who had prostatectomy done and they're getting that irrigation. Patients with hypothyroidism, this is rare but can occur. Psychogenic polydipsia, where patients are just taking water uncontrollably. Diapotomania, because they have low solids within their blood system. Some drugs, your diuretics, ACE inhibitors, patients who are exposed to a lot of exercise, and anything that would give you adrenocorticotropin deficiency. So that's a heavy slide, but I think it summarizes how to classify hyponatremia and the various causes or clinical states in which the patient can present in. Just one more slide on syndrome of inappropriate ADH secretion. There are various causes. You can have malignancies, you can have pathology within the CNS, so even meningitis, encephalitis, trauma, stroke, anything that will affect you or destabilize your central nervous system. You can have pulmonary disorders, pneumonia, TB is common in our setup, lung malignancies as well, and also not forgetting drugs. We commonly use anticonvulsants, antidepressants, and oral hypoglycemic agents. And in some cases, the cause is unknown. How would you make a diagnosis of SIAD? You need a low plasma sodium concentration, typically less than 30. The osmolality, as you've seen, will be low. The urine osmolality, not minimally low, be typically above 150. The sodium concentration may not be necessarily low. The patient of note, maybe the things that we are able to do readily in our setup, you can do a plasma urea, creatinine, uric acid, which may be low or normal. Then, of course, you'll have to rule out other causes of hyponatremia. So how do you go about treating these patients? First and foremost, you need to identify and treat the underlying disease if possible. There are patients who will recommend fluid restriction. Others will recommend sodium administration, and this can be given orally or IV. And in some other patients will put them on antidiuretic receptor antagonists. So we'll briefly look at what can be done. So of course, if the patient is volume depleted, you want to give them fluids. And for patients with primary polydipsia, you want to limit their fluid intake. So you need to give them like a target of what they should take, beyond which they should not surpass that amount. If the patient has adrenal insufficiency, there's a role of giving steroids. So the patients who are hypovolemic, you want to restrict fluid. So these are patients who present with heart failure, have liver cirrhosis, patients with advanced kidney disease. And it basically depends how much fluid you want to restrict. This is not fit for all, so it will be patient dependent, but at the end of the day, what you want to achieve is fluid restriction. And make sure the patient understands what you mean by fluid restriction. Like you give them a target of how much fluid you want them to take within the day. Then, so who gets sodium replacement? So as we said, this can be done via oral or IV administration. Usually patients who present acutely and symptomatic, those are the patients in whom we give 3% saline. And patients who can recover over time are given oral salt tablets if need be. And we should also keep in mind the risk of excessive rapid correction of hyponatremia. This can lead to osmotic demyelination syndrome, when this usually occurs within 2 to 6 days after a rapid correction of sodium. And basically, these patients, it is irreversible, so this is quite disturbing to the patient and the relatives. And as the clinicians, we should try and avoid getting the patient into this. So basically, they'll present with confusion, coma, or personality changes, and what is described as a lock-in syndrome, where they cannot verbalize or even locomote. Although they can hear what you're saying, they can understand, but they're not in a position to move or even talk to you. So it is recommended that you don't do a rapid correction. So you aim at correcting by at least, or rather at most 6 milliequivalents in the first 24 hours. If the patient has severe neurological symptoms, you want to correct the hyponatremia as fast as you can. But patients who present chronically, there's no role for rapid correction of the low sodium levels. So the other role is role of ADH receptor antagonist. This basically acts by blocking the action of antidiuretic hormone, and this leads to loss of water without any interference with sodium or potassium. Examples of this is you can give the patient tolvaptan or conivaptan. However, these drugs are quite expensive and not readily available, so most of the times you don't end up using them. So this is just a summary slide showing your approach to management for a patient who has hyponatremia. So first of all, you want to establish whether they have severe neurological symptoms. If yes, you want to rapidly correct this using 3% saline. This is given IV. If no, you want to try and establish the diagnosis and treat the underlying condition appropriately. So in patients who present with heart failure, liver cirrhosis, or nephrotic syndrome, patients who are basically in fluid overload, you want to restrict fluid. For patients with features suggestive of SIAD, syndrome of inappropriate ADH secretion, you also want to restrict fluid. But if the hyponatremia does not correct with fluid restriction alone, you can consider giving oral sodium tablets. And if the urine osmolality is greater than 500, you can consider adding a loop diuretic. Remember we said there are different causes of SIAD, and if it is related to a CNS pathology, like this, if the event that patient has a cerebral salt wasting syndrome, you'd want to give the patient hypertonic saline to help and correct that. Reset osmostat basically refers to patients who have a lower threshold for releasing ADH. So it is benign and asymptomatic, hence does not require any treatment. Of course, if the patient is volume depleted, hypovolemia can be life-threatening. So in such patients, you don't want to restrict fluid. You actually want to give normal saline to try and sort out the hypovolemia first. For patients with primary polydipsia, either due to psychosis or whatever other reason, you want to normalize their fluid intake. You give them targets in terms of how much fluid they should take. When you're using diuretics, you should bear in mind the different adverse effects of both loop and thiazide diuretics. Mostly, since they cause diuresis, they can cause hypovolemia. You're losing sodium, you're losing potassium, you're losing magnesium. For thiazides, you can get hypocalciuria, and the opposite is true for loop diuretics. There's also the chance of getting hyperuricemia and metabolic alkalosis. Also not forgetting the metabolic side effects, where you can have hyperglycemia and hyperlipidemia. Some of these drugs contain sulfur, so some patients can have hypersensitivity reactions, and also because of the hyperuricemia, hypercalciuria, some of the patients get cholecystitis and pancreatitis. So that's just about it when you look at hyponatremia. So we'll move to hypernatremia. We all know the normal sodium concentration is 135 to 145 millimoles per liter. And basically in hypernatremia, you have an impaired thirst mechanism or responsiveness to thirst. And if this is not addressed, the patient will develop dizziness, confusion, weakness, and can ultimately get coma and can result in death in the worst case scenario. So the clinical manifestations are more or less what a patient with hyponatremia will present with. So CNS symptoms, basically fatigue, nausea, vomiting, headache, confusion, seizures, coma. And just like in hyponatremia, the severity of these symptoms are related to the rate at which the derangement developed and the severity of the derangement. Same hormones come into play. So same your renin-angiotensin system, ADH, ANP, BNP also play a role in hypernatremia, and that one I've already discussed. So we said basically in hypernatremia you have unreplaced water loss. That is a main cause of hypernatremia, although you can have other causes like sodium overload, where you have increased oral intake of sodium or excessive administration of saline. And you can also have transcellular movement of water during vigorous exercises or when patients have seizures. However, what to note about this last column is that when whatever is causing the derangement is withdrawn, like if the patient stops doing the exercises, or if the seizure gets controlled, the hypernatremia will normalize without treatment. So the area that we'll concentrate on is this part of the chart. where you can have GI losses or diabetes insipidus, which can be central or nephrogenic, or you can have osmotic diuresis. So basically, in osmotic diuresis, it's just the loss of the osmoles. So in uncontrolled diabetes, you're talking of glucose, and also patients who've received mannitol. Diabetes insipidus can be central or nephrogenic, where in central with this reduced production of ADH in the hypothalamus, whereas in nephrogenic with reduced ADH, the production is okay, but there's reduced sensitivity of ADH in the kidneys, and there are various causes as outlined. GI losses or insensible losses, so vomiting, diarrhea, are the main causes. I think you can look at the table in more detail at your own free time, but just know the main issue in hypernatremia is unreplaced water loss, which can be due to GI losses or diabetes insipidus, which can be central or nephrogenic, or you can have osmotic diuresis. And in rare occasions, you can have sodium overload or transcellular movement of water. So when it comes to diagnostic evaluation of the patient, basically, most patients will present with a history of water loss, either through the GI, or osmotic diuresis, or excessive insensible losses. And you can also have a history suggestive of lack of access to water, either due to immobility or dementia or in small children. And all this will present with hypernatremia. Then the next thing that you want to check is urine osmolality. If it is less than 300, that points more towards diabetes insipidus. If it is more than 600, that points to reduced intake, so impaired thirst or reduced access to water. If it falls in between, you can either think of diabetes insipidus or osmotic diuresis. Again, when it comes to treatment, you don't want to rapidly correct the high sodium levels, because this can lead to cerebral edema with an increase in the intracranial pressure, resulting in seizures and ultimately death. So what is preferred is slow correction, because this gives the brain cells time to adapt. And the correction should ideally take at least 48 hours. That way you're sure that you're likely to cause any cerebral edema out there, but CNS complications that you've seen. So we've talked of the risk of excessive rapid correction of hypernatremia leading to cerebral edema. When it comes to acute hypernatremia, you want to correct this within a 24-hour period because of the consequences that will follow with delayed treatment. However, in chronic hypernatremia, you don't want to correct this rapidly, so you want a correction rate of less than 10 milliequivalents in 24 hours as you keep rechecking the sodium level so that you know the next action to take. So what fluid will you use? How fast will you administer the fluid? All this, just remember the main fluids that you want to use. You want to avoid anything that is hypertonic, because this will only worsen the situation. So preferably you can use what is called free water. This is water that is free of solids. So it's more or less distilled water that is preferred. However, you can also use 5% dextrose in water, or hypotonic fluids like half saline or normal saline. Then, of course, we said if the patient has concurrent volume depletion, this is also life-threatening. So this one should also be sorted out. And this basically means replacing fluid. And in this case, you can use normal saline. Next, we'll move to potassium balance. I hope you are all together. Are we okay?
Yes, doctor, we're okay.
Okay, fine. We'll move to the next portion of the presentation. So we'll be basically looking at the disorders of potassium balance, which can be either hypokalemia or hyperkalemia. We all know the normal potassium level is between 3.5 to 5, and anything less than 3.5 is considered hypokalemia, but most patients will present with symptoms when the potassium level is less than 3. but generally the patients will be asymptomatic. And for those who have symptoms, they're usually muscular in nature or cardiac. And again, the same diagram appears, meaning you should all be conversant with the several hormones that we've talked about. So when it comes to hypokalemia, you can either have reduced intake or increased GI loss, or you can have internal redistribution. The role of insulin catecholamines and also alkalosis can cause a shift in the potassium. And finally, you can have excessive renal loss. So coming to the classification of hypokalemia in terms of mechanism, we've already talked about this. You can have poor intake, GI losses through vomiting, diarrhea, laxative abuse, urinary losses, mostly drug-related, or when you have renal tubular acidosis. In internal redistribution, you have several hormones causing a redistribution of potassium from into or out of the cell, depending on what you're looking at. So basically, the patients, most of the patients will be without symptoms unless the potassium level is less than 3. And as I said, the signs and symptoms are usually limited to the muscular system or cardiac system. So they might present with weakness, mostly of the legs more than the arms. They can complain of muscle cramps, can have function of ileus, or can be a case of rhabdomyolysis with release of all the intracellular contents. They can also present with cardiac conduction abnormalities. We'll have a look at what the ECG will look like. So on the top column, you will appreciate the flattening of the appearance of the U wave. They have a prominent U wave, which is this spike, and ST depression, okay? And there's a flattening of the T wave here. So it is no longer here in this image. So this is basically summarizing the different causes of hypokalemia. So the effect of alkalosis, insulin excess, catecholamines can cause redistribution of potassium into cells. If you have reduced intake, this can be oral, or if the patient needed supplementation, it is not being done. All this can lead to excessive potassium losses. Same the thing like in sodium, you need to do your urine potassium levels. If they're less than 20, that means that most of the loss is not occurring in the kidney, it is occurring in other systems like through the GIT. So if the patient has a low urine potassium with alkalosis, you think of vomiting or esophageal aspiration. If there is acidosis, you don't think of diarrhea and laxative abuse if you have fistulas for post-op patients. However, if the urine potassium is more than 20, you want to differentiate if the patient has high blood pressure or a normal pressure. If the pressure is high, you think of issues to do with the adrenal system. So you can have hyperaldosteronism, which can be primary or secondary, or you can have other forms of mineralocorticoid receptor activation. If the patient has normal or low blood pressure, you think of either if the patient has alkalosis or acidosis. So then there are different causes of that. So you can have diuretic therapy or some of those congenital syndromes like Bartter's and Gitelman syndrome, renal tubular acidosis if the patient has a normal or low BP with acidosis. And if the patient has variable pH, you think of post-op diuresis. So when it comes to treatment, again, the more or less the same thing that we've been talking about. You want to replace the potassium, but this is dependent on the rate at which the hypokalemia developed and whether the patient has any other high-risk comorbidities, if they have any other ongoing cardiac issues. And so basically treatment should involve both addressing the underlying etiology and replacing the potassium. However, there has been no benefit in replacing potassium to a level of more than 4 milliequivalents. So when it comes to potassium repletion, you can either do this orally or you can give IV potassium. And of note, oral potassium, the major side effect is causing GI upset. However, the maximum dose that you can give is 40 milliequivalents at any given time. When it comes to IV potassium chloride, usually it depends on whether you have a central line or a peripheral vein. And just a minute. Sorry for the interruption. For IV replacement, it can either be done via peripheral vein or a central vein. When you're using a peripheral vein, you want to give smaller amounts, like 10 milliequivalent maximum. That's per hour. For central vein, you can go as high as 20 milliequivalents per hour. And all this is because of the burning sensation that the patients get when it's given IV. And for patients who have hypokalemia in the setting of diuretic use, e.g. patients who are in heart failure, you'd rather give a potassium-sparing diuretic as opposed to giving potassium supplementation. So we'll move to hyperkalemia, which is the last part of the presentation. Looking at the etiology or in the clinical assessment of the patient, mostly the patients will present with, again, muscular weakness, and they'll also have cardiac symptoms. And of course, not forgetting the ECG changes that come with hyperkalemia. Again, the same hormones play a role in hyperkalemia. When you're looking at the etiology, you either have potassium release from cells in hemolysis or rhabdomyolysis, or you can have low aldosterone levels or severe renal impairment. So looking at the causes in depth, we've talked of hypoaldosteronism and internal redistribution, and you have cell lysis or the effect of medications. So when you have tumor lysis syndrome, hemolysis or rhabdomyolysis, all this will result in release of potassium from the cells. It can have the effect of drugs, mostly beta blockers, and also digoxin toxicity can be associated with hyperkalemia. If you have insulin deficiency, acidosis, exercise, all this, they usually promote entry of potassium into the cell. So if there is insulin deficiency, you'll have hyperkalemia because there is no movement of potassium into the cells. Looking at aldosteronism in detail, it can be hyporeninemic or non-hyporeninemic, although that is not a qualified term. So in hyporeninemic, the primary issue is low renin levels. In the second category, there is usually low aldosterone levels, or you can have aldosterone resistance. And these are the various causes of the different states. So usually you can also have what is known as pseudo hyperkalemia, where probably when you're drawing blood, there's movement of potassium out of cells. And this can be due to the blood drawing technique, where you have mechanical trauma, when you're applying the tourniquet, or when the patient does an excessive fist clenching. And you can also have profound thrombocytosis or leukocytosis, all leading to hyperkalemia. So as I said, most of these patients will be asymptomatic until the potassium is way above 6.5, and they'll basically present with muscle weakness or arrhythmias when you connect them to the machine. So there are typical ECG changes that occur with hyperkalemia, but this does not necessarily mean that if you have a potassium of, say, for example, 6.5, you cannot get widening of the QRS. This is not cast on stone. This is just to show you how the changes progress with worsening of the hyperkalemia until eventually get what is referred to as the sine wave. But mostly it will start off with peaking of the T waves, then there's a widening of the QRS and flattening of the P waves, then eventually get the sine wave. So the bottom row depicts what we've discussed. There's a peaking of the T waves. Yeah, we can't appreciate the P wave anymore, which was here. There's widening of the QRS. And so this now forms what is known as the sine wave. So how do you approach such patients? First of all, you want to rule out any pseudohyperkalemia. So you watch out for your technique and any of the other causes that we've talked about. You want to review the patient's list of medication and of course their renal function. If they're in end-stage kidney disease, then most probably that is a cause of the hyperkalemia. And you also want to evaluate for hypoaldosteronism by checking their renin levels, aldosterone levels, and the cortisol level. So after you've done all that, you'll be probably at this point in the table. So you'd want to look at their plasma creatinine level. Of course, if it is elevated, you think of renal failure, which can be acute or chronic. And if the plasma creatinine is less than 500, then you'd think of the other causes that we've discussed, not forgetting the role of the different drugs that we've mentioned. I guess you can have a look at this at your own free time as well. So generally, when it comes to management, as we've discussed for the other disorders, you want to treat the underlying cause. Okay, so if there are any drugs that are causing this derangement, you would want to withdraw such drugs. Then there are different forms of therapies, the ones that act rapidly but are transient, and there are those that take time to work, but their effects are long-lasting. So I'll take it to the next slide. So first and foremost, if you come across any patient with hyperkalemia, the first thing that you want to do is to stabilize the cardiac tissue, and this is achieved by giving IV calcium gluconate, and this is given as 10 mL of 10% calcium gluconate as a slow IV push. Then you'd want to now shift potassium into the cells. Remember, this will be short-lived because once the drug wears out, the potassium gets back into the system. So for this, you can use beta-2 adrenoceptor agonists like salbutamol, or commonly we use IV glucose. You can get 30 to 50 mL of 50% dextrose and give it with insulin. In the instance that you don't have Actrapid, you can use soluble insulin at 10 units IV. And if the patient has acidosis, you can consider giving sodium bicarbonate. Then to get more prolonged effect, there's the role of diuretics and dialysis and even potassium exchange resins like resonium, and there are newer drugs called potassium binders, which can also be used. So we'll discuss briefly for your sodium polystyrene sulfonate, commonly known as kayexilate, which basically exchanges sodium for potassium in the intestinal lumen. So the patient passes out potassium too. So the main side effect is mostly GI upset. They can have nausea, vomiting, constipation. Rarely do they get intestinal necrosis, but that is something that you can bear in mind. And it is usually, this is what is commonly used and what is readily available to most of us. However, you can also use diuretics where need be, and especially if the hyperkalemia is mild to moderate and the patient still has reserved kidney function, and there are other indications for using diuretics, e.g. a patient who's hypervolemic in heart failure, has high blood pressure, you can still get the benefit of using the diuretics to sort out the hypervolemia and blood pressure as you sort out the hyperkalemia. But the most effective way to remove potassium from the body is hemodialysis, and this should be the go-to mode of treatment for patients with severe ECG changes, patients who have arrhythmias, and patients who are in end-stage kidney disease. However, you should know that there is a chance for getting rebound hyperkalemia after dialysis. And that is the end of my presentation. I welcome any questions or clarifications.
Thank you, Dr. Kibe, for this very clear presentation.
You're welcome.
We can just give a few minutes for the questions that there. Are you able to see them in the chat box?
Okay. Let me go. So how does SIAT cause euvolemia instead of hypervolemia? So basically for SIAT, you have inappropriate antidiuretic hormone production. So clinically, it is said that the patient is euvolemic, but I think this was asked by Josephine Ferranera. But in actual sense, the patient can fall in either side. They can either be hypovolemic or hypervolemic, but they're not at the extremes. So you cannot say they are overly in fluid overload or they are volume depleted. That is why they're classified as having euvolemia as opposed to either hypervolemia or hypovolemia. But this is because clinically it is difficult to tell which side they belong to because they can fall in either the hypervolemic state or the hypovolemic state. But clinically it is difficult to distinguish. That is why they're classified as euvolemia. How do beta blockers lead to hypokalemia? It depends on which beta blocker that you're talking about, but generally beta blockers have a role in cardiac function, and mostly when you talk about the sodium potassium ATPase pump, that is where their effect is most felt, and that is how they result in causing hypokalemia. I don't know whether that is well understood. How does vomiting and diarrhea cause both hyponatremia and hypernatremia? So it depends. If your volume depleted, okay, of course, from the GI contents, you'll be losing lots of solids and water as well. So it depends on the volume status of the patient. If you're losing more solid, like in hyponatremia, hypervolemic hyponatremia, there's water deficit and sodium deficit, but there's water deficit is more as opposed to hypovolemia hyponatremia, where the sodium deficit is more. So that is why it can fall in both categories. I don't seem to see any other questions. Unless there are some questions that I've missed. Any other questions?
I don't think there are any other questions, Doctor. So thank you for your time today.
I hope you've all learned one or two things that you can apply in your future management of your patients. All right. Okay, thank you everyone for attending. I guess I will share the slides with your representative.
Yes, I will email you.
All right.
requesting for the slides.
All
Great,
right.
doctor. Thank you.
Okay.
Everyone else, the class is still in this meeting. Please don't leave the meeting.